Hi, welcome everyone. My name is Margaret Lee, and I will be facilitating today's session on healthcare in the Lilly Conference. I see that some people are just streaming in right now, and so I'm going to give us a minute to make sure that everyone can join our session together. So I see so far we have 12 the number is going up very quickly, so people are coming in. For those of you who may just be joining in to the conference, welcome to the Lilly Conference, Reckoning and Reimagining, Envisioning a Faithful Presence in the Liberal Arts. This conference is designed to bring an interdisciplinary group of Christian scholars, clergy, religious leaders, and students who will offer insights, theory, and research for reimagining the liberal arts. We would like to provide a robust response to the global enduring impacts of COVID-19 related to health, justice, politics, and the economy. And so if you look at the schedule, you can see that there are these various topics that we're covering: health, justice, politics, and the economy, COVID-19, anti-racism, and this session is focused on health. We use the term health broadly to include physical health and mental health. And so you will be hearing presentations covering those areas. And first off, I just want to introduce myself. My name is Margaret Lee. I am a professor here at Azusa Pacific University in the social work department. I teach courses in diversity and social justice. I teach all of the policy courses. And one of the areas of my expertise is in health and mental health care policy. And so I'm very honored to be here to facilitate this esteemed group of presenters. Now I'm going to introduce them. We have Amanda Riedel, who was a doctoral student at George Fox University, and she will be presenting on reimagining religion in psychology. Our second presenter is Dr. Robin Pickering. She is the Associate Professor of Health Services and the Director of the Women's and Gender Study Program at Whitworth University, and she will be presenting on the racial divides and COVID-19, exploring social determinants of health. Our third presenter, Shelby Powers, is a doctoral student at George Fox University, and her presentation is titled Laboring for Justice, Sacred Co-Creation and Profane Inequity. And our fourth presenter is Cameron Visagie, who is a lecturer in the Department of Information Technology, coming all the way from South Africa. He teaches at the Cape Peninsula University of Technology and LA School of Mentorship. So we have a very diverse group of presenters here, both from here and internationally. And so, so I think we have a video that's going to be queued up that will present their four presentations, and then we'll have a time, maybe about 15 minutes for Q&A afterwards. And so as you're listening to these presentations, if you have any questions, feel free to drop it in the Q&A part, and then I will facilitate our Q&A discussion after all four presenters have presented. So thank you again so much for joining us, and I look forward to our discussion after the presentations.
A patient walks into your office defeated and exhausted. Being a single parent is difficult enough without the pressure of a pandemic pounding on the front door. The patient talks about the bill that was due last Friday and the burden of deciding if it is safe to visit their elderly parents. The kids are home all day long, making work from home a challenge. The normal support they get from their church family is non-existent. Not by choice, but just because the struggle the pastor is having to manage with what is safe through a pandemic is difficult. The patient reports a lack of desire to go on in life, which is why they finally came to see you. Psychologists are reported to be significantly less religious when compared to members of the American public. Religion and spirituality are commonly placed on equal ground without specific definitions for each construct. We struggle to operationally define religion and spirituality as separate entities, and I think this is a shame. I think we can do better. Faith or belief in a higher power does not need to be present for something to be religious. It might be less challenging to say going to the mall or attending a holiday celebration is sacred, but it is provocative to suggest the work of a psychologist is religious. The identity of many psychologists would be threatened with this realization, since psychologists historically are claimed to be one of the least religious groups of individuals. A psychologist wakes up in the morning and prepares for a scheduled day at a set location. They gather their notebook, laptop, and keys and travel to their destination. In a lobby, they meet with their colleagues, sipping coffee or tea, in community with their people. The office, hospital room, or classroom serves as a sanctuary for them to gather and wait of their other community members. Just as a pastor prepares for his message, a psychologist reviews notes in preparation for seeing a client. The ceremony begins with pleasantries and introductions, making sure the client is comfortable and content. The technique might be cognitive behavioral, person-centered, or psychodynamic. Just like a message can be delivered with an altar call, a more extended prayer time, or a call and response series. This interaction is key to building a relationship and enabling change in both the church and the therapy room. Both parties have the common goal of making the world a better place. While the therapist delivers the technique, the client wraps their hands around the therapist's gauntlet. They sit down, drink their wine, and eat their bread, expecting their own life to change forever. After a specific amount of time, the meeting is ended with a summary from the therapist of their time together, similar to the pastor sending off the congregation with a benediction. The next appointment is confirmed, just as the church members know the start time of next week's service. All parties file out of the sanctuary and continue with their day. Congregation/patients rejuvenated for the week, and therapist/pastor most likely exhausted. It is not a new concept to think of therapy as a spiritual discipline. However, my point is not to call attention to therapy as a spiritual discipline, but to point out that we are religious people, psychologists and all, no matter what the trend in culture is telling us. It is popular to stick our noses in the air and claim to be detached from religion, institution, and liturgy. Pulling away from this movement is difficult, especially as a 23-year-old Christian. I experience the tug of individual faith and the pull of organized religion. I think a strong step in this situation is recognizing the religion present in everyday activities. The global pandemic has called attention to our religious acts simply by intercepting them. The places, objects, and people we devote our time to end up becoming what we worship, since that is what we devote all of our time to. These habits are essential in acknowledging what we dedicate our lives to, not only as psychologists, but as Christian psychologists. Christians spend a lot of time separating Christianity and religion from the secular world. But God is already involved in the entire world. His creation, even the parts we see as bad, are beautifully and wonderfully made. The separation between Christianity and the world and feeling like we have to pick one side is comfortable because it is really difficult to hold things in balance. Moderation is always a difficult triumph. This ties into the separation of religion and spirituality. The pressure to choose a side leaves people feeling like they have to choose between religion and spirituality. I understand attempting to deconstruct the baggage the word religion often carries is not something that can be changed overnight. However, it does not seem like we have a clear definition of what religion actually means. The COVID-19 pandemic became a prominent issue for so many people because their religion was disturbed. And I'm actually not talking about the disruption of church services. The pandemic stripped our tendency to shop at malls, eat out at restaurants, attend family gatherings, and attend therapy sessions in person. COVID stripped away the religious acts we partake in before we realized they were things we worship. Throughout the pandemic, we have learned the power of uncertainty in a way that is unteachable and can only be experienced. We now know that not only are we flawed human beings, but we are also habitual planners that become enraged when our arrangements are disturbed. COVID resulted in a significant increase in enrollment of patients despite having to meet virtually. People are desperate for interaction. They are desperate for someone to care about them. With the support of a church and its pastor wiped out of the equation, people decided to find a different type of support. People have found this support in therapy. What if the support a psychologist provides is fundamentally and inescapably religious? What does it look like to meet with a client mentioned earlier who is drowning in financial burdens, trying to raise children, and mourning the loss of their church family? The reliability of attending a therapy session routinely is similar to the safety a church provides. The psychologist providing services does not need to be a spiritual individual, but it could serve as a benefit to recognize the work they are doing could be considered religious. My point is not to suggest that every psychologist should be a Christian or to insist there has to be a higher power involved in therapy. What I do want to do is point out that psychologists are not actually some of the least religious people, but some of the most. Thank you.
Hello. Though no one is immune to the impact of this pandemic that we're facing, in historical and in modern times, health disasters often disproportionately impact marginalized populations. Lead in the drinking water, mold and other damage from floods, loss of homes from fires, hurricane damage, often place a greater burden on minority populations and those living in poverty. The COVID-19 pandemic has been no exception. I recently heard somebody say, if we're listening carefully, the pandemic tells us a lot about ourselves. And I've reflected on that a lot. Early on in isolation, it amplified the parts of us that would be selfish as we all desperately ran to get toilet paper and other supplies. And later on, we jockeyed for position for vaccine distribution, deciding in the court of public opinion who was worthy to receive it. We've seen tremendous acts of courage from frontline workers. Perhaps at its worst, crises expose our deep vulnerabilities and those parts about us that aren't so great. But they may also serve as an urgent wake-up call, forcing us to reconcile, forcing us to really examine and reflect on where we're at. And if we listen carefully now, what is the pandemic telling us about how we treat our people? How can this inform the way that we talk about health? Risk for COVID-19 infection, hospitalization, and death varies significantly by race, with a disproportionate impact on communities in color of America, as you can see here. One way that we can conceptualize this sometimes predictive and curious connection between race and health in America is to better understand the social determinants of health. The social determinants of health, as you may or may not have heard, are the conditions in the places where we live, where we learn, where we work, where we play, as well as the complex, interrelated social structures and economic systems that shape those conditions. And though folks in the public health world have known for some time that social determinants of health are significant contributors to the health disparities that we see in the US, the pandemic has really amplified these systemic shortcomings, which place some individuals at a greater risk of both disease, exposure, and death if exposed when we're speaking of the pandemic. And though disparities in pandemic morbidity and mortality create a significant financial burden on vulnerable populations and a significant financial burden on the healthcare system itself, they've also served to amplify this urgent need to work from an upstream level and address social determinants of health if we're to make sustainable changes. Conditions that can increase disease vulnerability include aspects of the social environment. So things like discrimination, income, education level, marital status, the physical environment, so places of residence, crowded living conditions, the built environment, transportation system, neighborhoods, and health services, so access to health insurance, quality of care. And although these social determinants of health are largely beyond the control of the individual, they're largely responsible for the disparities that we see between groups in health, which creates unfair and avoidable differences in health status and health outcomes. The differences in exposures can predispose groups of people to chronic diseases like asthma, heart disease, stroke, cancer, and can also create stark vulnerabilities related to coronavirus exposure, disease presence, and hospitalization and death if infected. And even before the pandemic, clear health disparities related to social determinants of health have existed in vulnerable populations. So according to data from the Kaiser Family Foundation, in America, Blacks have higher rates of diabetes, hypertension, heart disease than other groups. And nearly 15% of Black Americans have diabetes compared with 8% of whites. Black children have a 260% higher hospitalization rate and a 500% higher death rate from asthma compared to white children. Hispanic Americans, 50% more likely to die from diabetes than non-Hispanic whites. American Indian and Alaska Native adults are 60% more likely to have a stroke than their white adult counterparts. So in the US, minority status increases the likelihood of comorbidities, immune suppression related to lifetime stress and hospitalization from the coronavirus and COVID-related death. So we've got these comorbidities existing at higher rates in groups and communities of color, which not only predisposes people to infection if they are exposed, but also predisposes them to hospitalization and even death if exposed to COVID-19. So in addition to the greater likelihood of comorbidities, communities of color face other challenges related to navigating the pandemic, which can impact morbidity and mortality. The US overall, comparatively, has poor health and chronic disease presence compared to that of most similarly developed countries. Additionally, to date, the US has the most coronavirus cases and deaths of any country in the world. Though the causes are certainly multifactorial, unique systematic factors and general poor health contribute to vulnerabilities and impact. The US healthcare system has fewer physicians, hospital admissions, and other services than most any other similar country, while at the same time having the most healthcare expenditures in the world. At the same time, many Americans lack healthcare coverage, with many people being uninsured. On average, major similar countries spend about $1.70 on social services for each $1 that's spent on health services, but the US spends 56 cents for each dollar spent on health services. 56 cents of each dollar that is spent on social services compared to each dollar spent on healthcare spending. So we're investing less in social programs, but spending more on health services in terms of treatment. So in addition, many of the recommendations given related to COVID assume a certain level of privilege. So many people don't have the luxury of social distancing. Many that are deemed essential workers have to make the choice of working in places with physical crowding or being unemployed. Children living in poverty also bear the additional burden of a greater likelihood of underlying health conditions and tighter living conditions that might make them more vulnerable. Minority status also increases the occupational exposures. So frontline workers, essential workers, are more likely to be exposed, but also school closures and disproportionately impact those who are homeless or living in poverty, as they increase food insecurity among those that rely on school lunch programs. So malnutrition in children has the reciprocal impact of impairments of the immune function, mental capacity, physical health, which carry the potential of increasing risk of disease transmission. According to the American Public Health Association, children living in low-income families are twice as likely to have asthma, which may be exacerbated by coronavirus exposure. Minority status also increases vaccine hesitancy related to earned mistrust of the medical system. So even though Black, Hispanic, and Native Americans are more likely to be hospitalized from coronavirus infection and more likely to die than their white counterparts, CDC data indicates that white Americans are being vaccinated at nearly 3 times higher rates than Black Americans. In addition to access factors, a lot of that hesitance comes from medical mistrust among minority groups. That has been well earned and documented that there is modern day discrimination observed in medical settings, in addition to the historical issues that have garnered mistrust. So what has, if we're listening closely, what has the pandemic taught us? If the assumption is true that health disparities are the result of equity issues related to social determinants of health and are created and not just happenstance, and if the assumption is true that the presence of poor health created by those inequities in social determinants increases the risk of exposure to and death from the deadly virus, and the statement is true that working upstream to address disparities in social determinants of health is part of a sustainable model to reduce equity issues in healthcare costs, then the education of students, the education of healthcare professionals, the education of the general public must include an emphasis on prevention by addressing the inequities that we see in social determinants of health. Thank you.
Racial disparities exist in many levels of healthcare, but a particularly shocking aspect of inequity in healthcare systems is the disparate rate of maternal and infant mortality between white women and women of color. Equity in healthcare involves protecting those most vulnerable to negative outcomes. In the area of perinatal care, Black women. And this is tied inextricably to our Christian spirituality. In many cultures, the experience of connecting the spiritual and the physical worlds is a privilege given to esteemed spiritual leaders who act as a conduit, a lightning rod for channeling the immaterial into the material. They encase the spiritual in humanity. In the Christian faith, I would argue that one of the closest experiences we have to witnessing the incarnational spirituality of our God is bringing life into the world through birth. This idea of the immateriality of the soul becoming materially alive in flesh, an experience reminiscent of the incarnation of God in human flesh, exists in sharp contrast to the experience of many thousands of women who leave their birth experiences feeling as though something terrible has happened. Something has happened to them. Rather than feeling the blissful exhaustion of delivering life into the world, they feel traumatized by the interactions they've had with those entrusted to guide them through this process, their healthcare providers. Instead of feeling empowered, they're grieved and bewildered. And for Black women in the United States, this mystical experience of labor carries a heavy weight of danger. They experience the highest levels of infant and maternal mortality, risking their very lives, yet entrusting their bodies to their doctors. This aspect of systemic racism in healthcare perpetuates the desecration of the image of God in humanity. Black mothers and Black children suffering at the hands of providers of healing. What a profane experience of indignity. And then to be sent home with a baby blanket and an admonition to rest well. Echoes of, but aren't you grateful your baby is healthy, swirl around new mothers with deep wounds, some of them physical. Many women following traumatic births say that their interactions with healthcare providers were a major factor in their negative experience. The doctors didn't listen to them, respect their bodies, or allow them to have agency over the experience. This underscores the role of systemic racism and implicit bias in healthcare injustices. Black women are ignored and disrespected in their time of deepest need. Just as much as medical complications can damage the body, medical providers who fail to care properly for these women can deeply harm their psychological well-being. So what if a Christian understanding of birth as a sacred privilege given to image bearers of God could help us reimagine birth? What if birth, instead of being just a routine medical procedure or something that happens to women, could be a glorious celebration of God's image being born unto us? What if healing the gaping wound of systemic racism in healthcare could begin with a recognition of the dignity inherent in Black women and Black babies engaging in humanity's most spiritual act? We might start with something as simple as revisiting dignity. God gives dignity. We affirm dignity, or rather we fail to affirm dignity in the case of Black mothers in labor and delivery. If these mothers feel unheard or disrespected, we must begin with why. All providers in healthcare fields who don't identify as Black, Indigenous people of color can explore their own biases and actively work to uproot these, not just can, but should, perhaps not just should, but have an obligation to, due to the weighty task they've taken on, that of healing the mind, the body, or the soul. As Christian providers, I argue that unlearning bias and uprooting racism is not just an obligation, but a non-negotiable. Our beliefs about the sovereign God who is near to the oppressed should provide an urgency that goes beyond a lecture or training here or there, but rather a robust reimagination, a reckoning with how perinatal healthcare is provided to Black women in America. America has been engaging in a reckoning in the past year or so with her racist systems. We've seen Black bodies, image bearers of God, destroyed by violence and gross injustice. Undoing ingrained patterns of racism involves every level of society and every occupation. And as we're each engaging in personal reckonings with injustice, we must also take up the task of critically observing, restructuring, and sometimes deconstructing the systems at work in our respective fields. My reimagined vision for perinatal mental and physical health care in America involves a trauma-informed, culturally informed, woman-centered approach to birth that involves the affirmation of dignity and worth given to each individual without condition. In this vision, healthcare providers and birthing mothers exist in an interplay of respect, trust, and compassion. Women's minds and bodies are honored. The sacredness of the birthing act is acknowledged in words, actions, and treatment. This might look like continued conversation between doctors and patients, listening to mothers' worries and desires, and receiving truly informed consent whenever and wherever possible. It might include mental health care for women before and after birth as a normal part of perinatal care. And it most definitely involves a deep intentional effort toward making healthcare services equitable and training providers to provide high quality care to women, regardless of their identity markers. And these might seem like simple things, perhaps so simple that we overlook them. But when we approach them with the mindset of respecting and honoring the spiritual power and weight that birth holds in the eyes of our Creator, the sacrosanct nature of the Imago Dei, these things hold the foundation upon which justice in healthcare can be built. When birth becomes a spiritually rich experience where providers recognize and affirm the dignity inherent in the women who make the immaterial material, we step into the beauty of bringing life into the world as a spiritual reality. We see God's face in the labor cries of women, God with us, God who suffers, God who bore indignity for the sake of his children. What we have done for these, we have done for him. Let that encourage our efforts towards seeking justice in the healthcare field in word and deed.
Academic health centers and the responsibility towards equity. Hi, I'm Cameron Visagie from Cape Town, South Africa, and I'm born in the colored group. Before I get into the academic health centers and the responsibility towards equity, I want to introduce two health systems to you, which is probably common across the world. One, the public, and the other, the private health system. So we all know in the public health system, the government is primarily responsible for funding the hospitals, to making sure that the population gets treated and has access to medical care. Perhaps it's actually a good medical care, but because the number of people entering the public health system is so much, makes that medical facility poor. Perhaps the government, in fact, is actually doing a better job than what private medical care is actually doing by virtue of the number of people that they serve. So we know that in public health care, people have to wait in queues. In fact, people may die waiting to get treated. This is the case in South Africa at least. And then we look at private healthcare. Private healthcare costs a lot of money. Many people can't afford private healthcare. Some may say, should they even be able to afford private healthcare? Then I ask the question, what is health? Should people be deprived of good healthcare? I don't know, that is perhaps for each individual to decide, and based on their ethics would come to some sort of a conclusion on that one. Now let us come and let us look at academic health centers. So what is an academic health center? An academic health center is one that comprises of clinical care, education, research, as well as clinical trials. So what does that mean for a patient going to an academic health center? One, physicians are being trained at these academic medical centers by some of the best physicians that exist in the particular country where the medical center is. Two, the patient has access to the latest research and clinical trials that is coming from that, as well as academic health centers has now in more recent years developed a focus on people in terms of or rather they've become more people orientated. So what does that mean? That means that academic health centers in fact look at issues pertaining to particular individuals or a group of individuals or an individual, perhaps a particular disease that is more common amongst a certain demographic. So with that said, they focus on what they call the social determinants of health. There are various lists of them. Some list 5, some list 4, some list 12. But let us just look at a few of them. Let us look at the social economic status. What that refers to the food security or food insecurity perhaps of a particular individual or group of individuals. What are they able to afford? Where do they live? What is the quality of infrastructure that they have? Are they living in a community filled with violence? Do they have to walk home and worry about a stray bullet hitting them because two gangs are fighting one another? What sort of trauma does that create within that individual? We look at education. Where have they been educated? Where has the individual been educated? Where do the individual have to send their children to be educated? What are the facilities at the school? When we look at apartheid in South Africa distributed at the time 670 rand or around there to a school of European descent, whereas Indian schools got 189, colored schools got 139, and black schools got 39 rand per child. What has that in fact done to those particular individuals? And further, even when it comes to tertiary education, people of color was denied access to universities at the time. So that is education. What does that do to the individual? Where does that place their mental state or the state of their physical health? Then we look at, have they been discriminated against? I've just basically mentioned some discriminatory things now, but have they perhaps been shouted at? Have they been called stupid by a person from another demographic? I think about myself. I've been told up front that I'm basically dumb. I'm dumb. I don't know what I'm doing. I don't know what I'm talking about because this particular individual, in fact, younger than what I am, knows better than what I do. I do not know if they even got an academic qualification, but they perceive themselves to be superior than the next individual. So, in addressing these situations, academic health centers can step in by understanding what are the health-related issues for that particular individual, for that particular group of individuals, for the demographic that the individual exists in. When we look into historical trauma that people experienced during the apartheid era, how did that affect those individuals? Being forced out of their homes in District 6, watching their houses being crushed and flattened to rubble, and then being moved 30 to 40 minutes out of the city center where they've lived before, and then having to travel into work in peak traffic, sometimes taking up to 3 hours to get to their place of work, leaving the children behind to go tend to the master's kids and make sure that their kids get to school while their children are actually not even having a loaf of bread to go to school. Those traumatic experiences affect the physical and mental health of an individual, because those historical traumatic events in fact change the DNA or the genes of the individual, and making them more susceptible to various forms of physical and mental illness. So does that apply to everyone? Perhaps not. Perhaps others were able to bridge that gap. Some were perhaps just lucky to get out of that situation and moved on to perhaps something that is perceived better. So we look at all these things, and we need to understand how this affects the individual. We can't just turn around and say that, or do research and say that colored people are more susceptible to blood pressure or cardiovascular disease. Black people are more susceptible to commit suicide. Yes, perhaps that is the case. That is the result of things like not teaching the child mathematics because of the demographic. That is the effects of people unable to find work because of the color of their skin. That is the effect of people unable to purchase a vehicle to get from point A to point B, having to use public transport. Imagine, we just experienced COVID-19 now. The main form of transport in South Africa are taxis with 12 to 14 people sits in. How do we address that situation? People have to first of all earn money, they have to get to work to survive. These are the things that academic health centers can step in and address. What are the root causes of a particular demographic's illness or individual illness? Perhaps how has a particular disease come about in a certain group of people, and how can that be addressed in order to not perpetuate these discriminatory cycles in individuals, not perpetuate ongoing inferior education for people of color, which is currently still the case in 2021, and therefore move towards eradicating or eliminating those things, or perhaps even just reducing a little bit more, in order to create a better society or a more healthy society, more healthy individuals, a stronger population, so that we can grow our economy at the end of the day. Because a working economy is going to benefit everyone. People with good health is going to benefit everyone. It's pointless having one demographic or a few people being able to access private healthcare or better healthcare, while the rest of the population is unable to access it. Yes, we understand that these are complex issues that perhaps has to be dealt with by private and public sector, but they have to be addressed, and in order to create a better person and a better population. Thank you very much for listening to my talk. Cameron Visagie, Cape Town, South Africa, born in the colored group.
All right, thank you so much to our presenters. On behalf of the Lilly Conference, I would like to extend my sincere gratitude to our 4 presenters for sharing your expertise and wisdom with all of us. It's certainly a very timely discussion, as we are in the middle of not only a global pandemic, COVID-19, but we're also in the middle of an awakening to the pandemic of racism that has been part of the American story, as well as very much a global story, as Cameron Visagie has discussed. In this session, we're able to see what happens when structural racism and health intersects. And our presenters have discussed some of the whys and the hows of how we can respond as a society, but also how we can respond as Christian practitioners and scholars. We can utilize our expertise through our academic health centers and academic health-oriented health departments, as Cameron Visagie shared. We can expand the capacity of mental health care services, as Amanda Riedel and Shelby Powers have discussed. And we can better understand how social determinants of health, as Robin Pickering explained, and examine where we work, play, worship, get our food, where we create relationships, how these things can impact health outcomes like maternal health care, and even what we're experiencing today with COVID-19 infections, hospitalizations, and mortality rates. So I just want to give a huge thank you again to our presenters for sharing this valuable information with us. We're going to transition into a time of Q&A. We have about 15 minutes, and anyone is welcome to submit questions. I'm going to help facilitate the Q&A portion. So you can just see at the bottom of your Zoom if you want to submit any questions. And while we're waiting, I do have a few questions that I've prepared that I'm going to ask the presenters. Anyone else is welcome to submit questions, and I'll be sort of watching that part of the Zoom. The first question that I have is, it's a two-part question, and anyone can answer on the panel. How is the discussion of health disparities relevant to our faith as Christians? And is this something that we should be learning about in our churches?
I'd love to speak to this. I think this is sort of at the root of the work that, or the research that I've been doing on the topic of maternal mental health care, and really health disparities for women of color in birthing experiences. I think it really comes down to, for me, this idea of us being image bearers of God, and us having this God-given dignity and this worth that is not given to us by other people. It's given to us by God, but we have a responsibility to affirm that, to see it, and to affirm that worth in other people. And so I think when we're looking at, like you said, this pandemic of racism that's really desecrating the image of God in other human beings, we're disrespecting the image of God. This is a fundamentally Christian issue, right? Like, the disrespect of human beings is a fundamentally Christian issue if we believe what we say we believe about creation, about the redemption that Christ brings. So I think this absolutely is something that we can and should be talking about in our churches, and this should be something that we're not shying away from, this idea of how the racism pandemic is affecting mental health and physical health and all of these things. I think really that it shouldn't be something where we tiptoe around it, or we sometimes have a sermon or two on it, but rather that it's very core and foundational to our collective identity as the body of Christ. And I would love to see it integrated more into our spiritual disciplines, our conversations in the church.
Mm-hmm. Great, Shelby. Would anyone else like to answer that question?
I can chime in. And thank you, Shelby. That was beautifully put. As Christians, we're certainly called to love our neighbors, which then brings us to examine, what does it mean to love, and who is it that is our neighbors? And I think in terms of social determinants of health, it is really the most basic way to show our love for people, to provide for the most basic floor level of that Maslow's hierarchy of needs, housing, food, all of those basic necessities are certainly part of love, to make sure that people have their most basic needs met. And further calling us to examine, who is it that we view as our neighbors? And I would argue that it is all people. And if we are to truly accept that that is our calling, to love our neighbors, then we have to reckon with that and grapple with what both of those things mean. So I think the church is a foundational place to have these conversations. And I think that we, in the church, sometimes love just some of our neighbors, or the neighbors that look like us, or live by us. And I think it's a really important time to ask these questions.
Great. Thank you so much, Dr. Pickering. Shelby, you have a couple questions that I'm going to ask, but of course, anyone is welcome to answer these questions if you happen to want to add to the discussion. So the first one is, where did you find the inspiration for your work? And next, how would you advise or recommend integrating faith traditions, beliefs that are non-Western or non-Christian?
Yeah, great questions. For the first one, in terms of the inspiration for this work, it really started, I think, when I started, well, one, the statistics on racial disparities in maternal health care are abysmal. I mean, there are some scary statistics in there. And I realized that this wasn't getting a lot of attention. People aren't really talking about this. And giving birth, really, if you think about the the sustenance of our population, people are giving birth a lot. This is something that happens, many, many hundreds of thousands of times a day. And the proportion of women who are experiencing trauma in their birth experiences, especially women of color, is kind of terrifying and a little disappointing that we're not talking about it more. So it was that, and really the area of birth trauma in general is sort of my the area that I'm interested in research and practice. So yeah, just I've kind of felt connected to that neglected area of both healthcare and of racism in just kind of systems in general. So thank you for asking that, for being curious about that. What was the second question?
How would you advise or recommend integrating faith tradition or beliefs that are non-Western or non-Christian?
Gotcha. Okay. Yeah. So that's a great question. I think what's foundational about this idea really is the idea of human dignity and worth. So I don't think that that's something that's unique to the Christian faith. I think we know where we get our idea of human beings having inherent dignity and worth, which is, we're created in the image of God. But I think in other faith traditions, there certainly are other ideas about why human beings have worth, or what it means to have worth as a human being. And so I think when we look at that, it doesn't, my background and my perspective obviously is Christian, but I don't necessarily think that you need to be a Christian to have your foundational values be on every human being deserves dignity and worth, and then racism being an affront to that. So racism being something that really desecrates this idea of human dignity and worth. So I really am not an expert on any other religions. I don't know specifically how that would be integrated, but I think that's a really interesting thing to look into, because obviously not all the providers who are involved in the birthing experience are coming from a Christian perspective. So maybe how do we integrate both religious beliefs, spiritual beliefs, lack of religious beliefs into the healthcare system, and allow that idea of dignity and worth to still be the foundation of mental health care and physical health care for women of color? That's a great question, something definitely to learn more about.
Great, thank you so much for sharing. The next question, I'm going to actually pose this to Cameron Visagie, because I think you have some unique experience coming from South Africa. So, we have a couple questions about collaborations, public-private partnerships, and even the prior question about integrating non-Western beliefs, non-Western practices. Have you seen in South Africa partnerships outside of maybe, traditional health systems, partnerships with communities in South Africa where they're able to maybe integrate more indigenous forms of care, of networking, and somehow that maybe serving the needs of diverse communities better?
I can't really say that there is a very distinct different medical practice. I mean, the traditional healers in South Africa use basically traditional medication, and they're vastly different to the normal Western way of working. So I haven't personally seen any collaboration between the two, but I do know very well the two does exist, and it's very common in South Africa, and it's actually recognized as well, especially in the more traditional communities. I myself, like I've said, I'm born in the colored group, and we pretty much, although we mixed race individuals, we kind of still westernized in some sense. So I haven't experienced that myself as well. I don't know if I'm answering the question or
Yeah,
giving
no, it's
some.
great. It's so interesting to hear perspectives from outside of our Western American lens. Thank you. And I know just personally, there are a lot of public-private partnerships, even here in California, that do utilize non-Western forms of healing, and that has been shown to be very effective in reaching out to unreached, underserved populations, including as it relates to maternal health care. So we have another question from Emily Greisinger. Do any of you see a role for the arts, film, poetry, literature, and raising consciousness of the problems you are addressing?
that because it's fresh on my mind. We, at our university, we have had some of our theater folks tackle some really powerful plays and musicals as of late that are looking at things like HIV and some different social and health related issues that I think are pretty bold and brave for a Presbyterian university. And immediately following, and unfortunately this year, of course, we've had to do Zoom performances, but immediately following, they've asked some of us, so people in psychology, people in social work, people in my field, health sciences, to do panel discussions to sort of tackle the themes that were discussed in the video. So Angels in America, where it's looking at HIV/AIDS and its early presentation in the US, and then sort of deconstructing some of that in our various fields. And it's been a really neat way to combine the academic side, not academics, arts is certainly academics, but I'm struggling to find the right word, combining arts with us sort of tackling that from the lens of our fields. And that's been a really nice way to integrate that I thought was really thoughtful and intentional.
Thank you so much. We have another question from Joshua Canada, and this question is about our educational institutions. So I know we have some graduate students here, so you can think of this question as your role as a professor, as your graduate student, but think of your universities as I ask this question. How do we shape educational institutions to cultivate graduates who are equipped to address, not only care about, healthcare disparities, particularly based on race and class? So I'm going to ask that again. How do we shape educational institutions to cultivate graduates who are equipped to address, not only care about, healthcare disparities, particularly based on race and class? What structural and pedagogical changes need to occur?
Hopefully I'm not talking too much. I will, only because I'm really excited about this question. One of the things that I've done, I teach a course called Community Health. And what I have done for this very purpose, because I found that, I've been teaching it for 18 years, and I found that it was sort of all about the caring part and the awareness part, and missing in the action part. And especially for people who weren't going into community health, but were going into medical practice. So I divided into two sections. One, social determinants of health and all the things that cause all of these disparities. And then the second half being, so now what do we do about it? And it's further divided there into a sort of acute things or episodic things that we can do, and then longitudinal things that we can do. And so I've had them practice writing opinion pieces. I've had them practice being forced to write letters to legislators, to figuring out how to go on to, in our case, the Washington State legislative list of all of the bills that are out there that address some of these areas, and having to go out and do legislative action days and doing sort of those episodic things, and then looking at bringing in speakers that are doing more longitudinal things and having them talk about how that plays out in the real world. And I have really found that to be powerful, because a lot of them know that they care about this stuff, but don't necessarily know that how much of a voice they have outside of just taking part in a protest or something. But giving them the skills that they need to contact legislators, to write letters. I make them write a letter to the paper, and several of them get published each semester. And that's really been exciting for me to watch them be empowered in that way.
Thanks so much, Dr. Pickering. Amanda, we haven't heard from you yet. And since you're a student, I was wondering if you could answer from the perspective of a graduate student, what could your institution do to help students be equipped to address healthcare disparities as it relates to race and class?
Yeah, I love what you were sharing, Dr. Pickering, and I feel like that was a very practical example of things you can do. And I think in a broader sense, my mind just goes to like free thinking and the ability to have safe conversations and open and honest conversations. I think we've been exploring that a little bit in our program in some of the classes that they've added to our curriculum regarding diversity and also integration. And that's made a world of a difference for me to be able to think outside of the box and not feel like I'm going to be reprimanded for it or put down in any way. And so allowing that freedom of space to be safe and to be free is where a lot of those ideas can come and become practical instead of just a thought. So yeah, hopefully that helps answer the question.
Yes, it's also so helpful. I know we have a lot of instructors and professors here. Really helpful to hear from the student perspective of, that you want to be empowered in your learning in that way. So we're at 11:41 now, and that wraps up our time. Again, a huge thank you to all of our presenters for sharing your wisdom and expertise. Thank you to our attendees for coming and spending your time to learn about healthcare at the Lilly Conference. And so I think we are saying goodbye, and maybe we'll see each other at the next workshop. Bye, everyone.